Hey, GeriPal listeners, before we start this podcast, we just want to make a big shout out to this HPNA HPM Denver Annual Assembly. And Alex, what's going on Thursday night?
We are doing a can't miss event, the GeriPal Pub Crawl, Thursday night. Please bring your friends. Please come yourself. It's a great way to see the city. Eric, where are we starting?
We're going to start at 8 p.m. at the Celtic or Celtic. Depends on kind of where you live, how you want to pronounce that. Details can be found on the GeriPal website. Just Google HPM Party Denver GeriPal, and it should be the first thing that shows up. And on with the show. Welcome to the GeriPal podcast. This is Eric Woodera.
This is Alex Smith.
And Alex, today is a battle royale on the GeriPal podcast. Yes. In one
Lynn,
corner, Alex. One corner, weighing in with decades of experience. Known for heavy hits of bedside assessments, strong patient-family relationships, and a knockout punch of interprofessional collaboration, we have in-person palliative care, Alex.
Yeah, go in person. Okay.
On the other, we have the young upstart. Telehealth delivered palliative care. It could reach far distances, Alex.
Long reach.
Long reach. All in the comfort of it wearing its pajamas, which is pretty impressive. We have telehealth delivered palliative care. Who is going to emerge victorious, Alex? Who is going to be answering that question for us?
Answering that question today, we have Joe Greer, who's a psychologist and associate professor of psychology at MGH and Harvard Medical School. Joe, welcome to the GeriPal podcast.
Thanks so much for having me.
And we have Simone Rinaldi, who's a palliative care nurse practitioner and director of nursing for the MGH division of palliative care and geriatric medicine. Simone, welcome to GeriPal.
I am so glad to be here.
And returning guest, Vicki Jackson, who's a palliative care doc, chief of the division of palliative care and geriatric medicine at MGH, professor at Harvard Medical School, and co-director of the Harvard Medical School Center for Palliative Care. Vicki, welcome back to GeriPal.
Thank you. It's a pleasure to be here.
And in the room with us today, we have Lynn Flint, who's an outpatient palliative care doc, frequent guest host at GeriPal, and professor at UCSF in the Division of Geriatrics. Lynn, welcome back.
Thank you very much.
So Joe, Simone, and Vicki were all authors of a great telehealth versus in-person palliative care study published in JAMA. JAMA? JAMA New England Journal. JAMA, that was just published not too long ago. Before we get into the results of those studies and what they did, somebody has a song request for Alex.
Indeed. Yes, we thought Hello by Adele would be thematic for our conversation today.
Well, is it just because it sounds like a telephone call?
There's layers of meaning in those lyrics. If you can dig deep.
All right, let's hear it, Alex.
Hello, can you hear me? I'm in California dreaming about who we used to be when we were younger and free. I've forgotten how it felt before the world fell at our feet. There's such a difference between us and a million miles. Hello from the other side. I must have called 1,000 times to tell you I'm sorry for everything that I've done. But when I call, you never seem to be home anymore. That was fun.
That was intense.
Well, I'm trying to get some other people to sing, but some people refuse to sing along. How can you not sing along with Adele? Have you seen the Saturday Night Live where the family's arguing and one is like very Republican, the other is it's Thanksgiving dinner, but then somebody plays Adele and everybody, hello.
One day Zoom will get it so we can all sing together.
That's right.
That's right.
Without a lag. That's what I'm waiting for, Alex. You get that going, and then maybe probably still won't sing. Okay. Let's talk about who is victorious in-person consultations versus telehealth. So I mock a little bit, but you published a great JAMA paper on this big study. Would love to I'll turn to you, Joe, to start off. First author, why did you and your colleagues decide to do this study?
All right. Well, this was back in 2017 when we were originally conceiving of the study. So well before the pandemic and before pretty much most of us were doing anything related to Zoom or telehealth via video visits. And
was Zoom a thing back then?
I mean, certainly not in
we were
our
all on
institution.
Skype.
Skype. I remember Skype. Yeah.
It was like the Flintstones version of video visits. It was pretty antiquated. Over the last couple decades, Vicki and other leaders in palliative care, and Dr. Jennifer Temmel, our thoracic oncologist colleague and co-PI on this study, we've been testing the early integration of palliative care in clinic through several studies. Our group was doing this, several other groups, actually a number of groups across the world were running these types of trials, and all demonstrating really decent efficacy for improving quality of life for patients with advanced cancer, and in particular for patients with advanced lung cancer. And so we were celebrating the great model that this was and how it was improving patient and caregiver experience, and hoping that that would translate into practice change. Got adopted by ASCO's quality initiatives and guidelines, and others like the National Comprehensive Cancer Network and other societies had recommended this care model as standard of care for this population. But in reality, given workforce shortages and just the challenges and the resources necessary to be able to provide early integrated palliative care from the time of diagnosis of advanced cancer, the model simply is not implementable, at least not in our current state with our available infrastructure and resources. So we were moving from this thought of like, we know it works, but how do we get it out there in a way that people can actually do it? And so the scalability question is really what was driving us to think creatively about improving access and efficiency in care, in delivering this model of care. And so that's how we landed on telehealth as one potential option, not the only option, but one option to really improve that scalability and improve that access. So we were just very pleased and excited that ultimately some funding organization agreed with us and gave us about $10 million to run this study across 20 different sites, or actually 22 sites across the nation. And here we are 7 years later with a JAMA publication.
A lot has changed in those 20 years. But before we actually talk about what you did, Vicki, I got a question for you. I think we asked you this question the last time too. Like, how important is it that we dissect all of these different ways we can deliver palliative care, either different populations, telehealth versus in-person, physician NP versus physician social worker? Like, how important is it that we really drill down into how we're delivering that palliative care syringe?
Yeah, I think it's a great question. I think one thing that was humbling in a study, the follow-up study we did to the New England Journal study, which was expanding a monthly in-person model into a GI population, is we saw differences in how that intervention impacted the patient's experience and their quality of life, right? We replicated the findings in the lung cancer population, and it wasn't until 24 weeks with the GI cancer population. So I think what I love about our field is we are really early on in understanding what is it that really makes a big difference. How do we structure it? What do different patient populations need? Like, if you think about it, that was still a cancer population. But how do we think about the right outcomes and the right intervention frequency and structure in heart failure, in, advanced liver disease, all of these things? So I think it's really important that we understand, and we can maybe at some point talk about one of the things that is most interesting to me is what we have really understood. It is a thread in all of these is really mediating what we're seeing in all these patient-reported outcomes, which is coping. So I think we have a whole host of different models. We could think about different ways that different clinicians who might be able to provide different parts of the model and allow this work that we're doing that we know now is really effective and helps patients to be more scalable.
Great. So maybe we can jump in. what did you actually test in this study?
I guess I can take that. So we essentially were testing the early integrated palliative care model, which is monthly visits with a specialty trained palliative care physician or advanced practice provider for patients who are diagnosed with advanced non-small cell lung cancer. So they had to be within 3 months of diagnosis. And they were going to be randomly assigned to either the traditional model that we've been testing, so delivering those monthly visits in clinic, often in tandem with their other oncology appointments. And I give a huge shout out to all the clinicians who are on this study, the 100 plus clinicians who like bend over backwards to work with their schedules and see those patients in clinic.
And you tried to see them in the same day that they were seeing oncology.
To the extent possible, they would see them in the infusion suite. They would see them in the oncology, center, like wherever the patient was, the clinicians were going there. And that's why this study was successful, because of their tremendous flexibility and generosity. So comparing that to the same dose in frequency and, focus of conversations in terms of, what is key and critical to the early palliative care intervention in terms of topics, all of that, all similar, but now delivered over video visits, those monthly video visits versus in-person care. So no differences between the modalities. Otherwise, the only thing we were varying was just whether it was in clinic or delivered over video. And the sample size was roughly 1,250 patients. So broad scale, 22 centers across the nation. So a pretty definitive and robust study to answer that question.
So can I ask you a wonky methods question? Because it was a big sample size, much bigger. We just had Jennifer Tamel on a couple months ago and others to talk about stepped palliative care. And she talked a little bit about the difference between non-inferiority, efficacy, and superiority trials. And it sounded like big difference was like the power and the sample size calculation. Why did you pick was this an equivalence study? Equivalence, that's the word I was looking for. Why did you pick an equivalence study instead of a non-inferiority study versus superiority?
Right. So I would say in terms of the question around superiority, we didn't have any particular data where we thought this particular modality, either video or in-person care, would be superior, right? We didn't think that there was something unique to the modality delivery in which palliative care was providing that care and having these types of conversations that are so meaningful, especially from the onset of an advanced diagnosis like that we thought theoretically or empirically one would be better than the other. Really, this was just an open question for us. Like when we pit these two modalities against each other, are they able to perform at a decent similar level was the question. The stats question and the methods question you're asking is like, really, should this been a non-inferiority versus an equivalent study? And in retrospect, it probably would have made sense to have this been a non-inferiority study, meaning that video visits were just as good as in-person visits. So it's kind of really the question. Whereas an equivalence is saying, are these two modalities really within the same band of improvement? Not one being less or one being higher than the other. And you could make the argument, like, if one beats out the other one, especially if video visits did better than in-person visits, again, we didn't have a hypothesis that would be the case, that would obviously be picked up from a non-inferiority study, just as good as or even better. But we were really kind of hemming ourselves in, saying that they had to be within a certain range to be equivalent. And that's not really the question, actually. Yeah. We're really just more curious if they were comparable. Yeah.
But that did mean you had a big sample size.
It 1,200 patients. Had to have a huge sample size.
That was no joke, just to be clear.
Yeah.
What was no joke?
Getting that many people?
Oh.
Yeah, and having 22 sites that we had to train, keep motivated, understand a very complex study. I mean, Simone, you can weigh in here, but those meetings to keep every site had different things that were struggles.
And I think that was the power of we had monthly meetings with all the centers across the country to be able to talk about, where things were going well and where the challenges were. And part of the power of those meetings, I think, was learning from each other about strategies for where things weren't going well that helped us as we all got stuck, because we all got stuck in being able to move forward with recruitment and other kind of operational and implementational issues.
How did you make sure? Did you make sure everybody was delivering the same type of palliative care intervention, or did everybody just do what they do in their palliative care clinics and you just saw what happened?
Well, it's a good question. So part of what we did was have all the sites trained up front, and I would say we weren't doing training on symptom management, for example. We assumed everyone was pretty clear and well skilled. I would say that many sites, seeing patients so upstream that they didn't have symptoms, we sort of had this language that we talked about with the sites of like, what do you do during the well times, right? Because there's actually work to be done there. But many of the clinicians would say, I don't know, how am I being helpful here? They're not dying. And I'm like, that's the point. Therein is the point, right? But so then it was really helping them think through a framing for the work. And part of the way we framed it was that because we've known from our previous studies that how patients cope when they see palliative care early is really driving a lot of these outcomes. We really spent a lot of time helping the clinicians see that a patient's illness understanding and prognostic awareness was just as important as their pain scale. Their pain score, right? And that they actually had to see that as a clinical domain that they addressed in each visit and subsequently over time, and to see that as a, we often say to our trainees, when we're talking about these things, getting to know a patient, helping them understand their illness, it might seem like we're just being really nice. And in fact, I think hopefully most days I am nice, but that's not why I'm effective, right? This is actually a skill, and helping the clinicians think about it as a skill was really important. And so we reinforced that over time in yearly trainings, in upfront trainings that got reinforced in these monthly meetings where, what was great about these monthly meetings with each of these sites is they would bring not only their concerns about recruitment or something related to the study, but also clinical cases, and say, what do I do with this? The patient refuses to ever talk about the fact that this illness could take their life. What do we do with that? Yeah. And it actually allowed for really rich discussion of, if you get to care for someone over the course of 1 or 2 years, how do we titrate our intervention to really help them live well?
I have a quick question. I think, if I'm correct, you did a in-person visit for everybody.
We did.
Can we talk a little bit about that?
Like, why did you do that?
Yeah.
Why did the telehealth get an in-person initial visit? Was it for opioids so you could prescribe them?
No. I think this was initially because this is before the pandemic, and people had a lot of hesitation about video visits and could you establish a relationship over video from the get-go. And so when we were conceiving of the study, we had various stakeholders and constituents that were serving in an advisory capacity for us, and both our patient and caregiver collaborators and our clinician collaborators all unison agreement to say, you need an in-person visit to establish rapport before transitioning to video visits. And I'm not sure we would say that today, but at the time that was super meaningful. And so we modified the protocol based on those recommendations.
Simone, what do you think? Do we need that today? If you were to do that study again, let's say, imagine the study didn't happen. You're doing the study now. Do you feel like you would need to have that in-person first visit in the telehealth?
I think that's part of the wonderful outcome of this study, to be able to, I think, answer the question as no. I don't think that we need it now. I think we were very concerned about it at the start of the study. And everybody was on the same page that we would have an in-person visit because we were so concerned about the ability to establish rapport. Because in going back to like what Vicki was saying, across all of our studies, we've been able to see that thread of coping.
Yeah.
I think we've also been able to see the thread of rapport building, and that the essential piece of rapport building and relationship as something that allows for everything that comes after. And so at the start of the study, we were so concerned about, can we really establish the same kinds of rapport and relationship with patients using this modality? And I think we have an answer now.
So wait, before we get into the answer, I got another question. I want to just highlight that I loved the supplement actually. On like page 23, it actually breaks down based on initial visit, follow-up visits. And at the end, like end of life care was not talked about at every starting of every palliative care clinic is that may be discussed, but the heart of the initial visit, it sounded like, was relationship and rapport building. And then there was a lot of stuff on coping and symptom management. I think for me, it just highlights a lot of kind of what we do. But I also thought this was mainly delivered was this the same as the stepwise? It was physicians and APNs?
Yes.
Yes.
Not the whole interprofessional, but what about the social workers and the chaplains?
Yeah, it's a great question. It really depended on the site. So some sites had, so like our site at MGH, we have cancer center social workers who are very engaged, find themselves very well versed in palliative care, and really want to be the primary people supporting patients in the thoracic clinic, for example. So those social workers were involved. We would make referrals to psycho-oncology. I would make referrals to Joe as well as part of the team. But there were some sites where social work would be really in a palliative care social worker more embedded in the model. But it was not uniform across all sites.
So just to piggyback on that, the protocol stipulated that the monthly visits would be administered by either, board certified, specialty trained palliative care physician or an advanced practice provider. But that did not limit those clinicians from making referrals, as Vicki was just saying. And to pick up on your prior question about how did we know what they were doing? I mean, another measure of fidelity is that at the end of every encounter, whether in person or over video, the clinician completed a standardized form indicating this is where you were talking about the supplement. I love that you read the supplement. We put so much work into
word
that supplement.
for word, Joe.
Yes.
A lot of work.
I found the Easter eggs in there too.
There's so many great nuggets there. So thank you, especially the hours I slaved over that supplement. But when you look at those actual graphs of the topics being discussed, and it's actually not just the initial visits, over the course of all the visits that we had, 5,000 plus clinician forms that were filled out. I mean, just an immense amount of work. I think two key themes come through there, which is one, these conversations are remarkably similar regardless. The frequency and the topics were remarkably similar regardless of the modality. And also on those forums, we do note, I mean, that part wasn't in the supplement, unfortunately, but we do have the information about referrals to other ancillary providers as part of that, that multidisciplinary team. So it matters. It's a piece of the intervention. It's just what was required per protocol versus kind of like what is patient specific, site specific, as Vicki was mentioning.
Yeah, Lynn, I've talked to you about this. Is like there is a difference, right, between assessing someone yourself as a physician for social work needs and then making a PRN referral versus having a social worker integrated in your clinic where they're seeing the patients, doing their assessments, managing coping. Do you feel like that's true?
For sure. Yeah. I think we try to do visits together with the social worker in our first assessment, even if it's on video. And I find that when that happens, the social worker is usually able to do more integrated follow-up over time, even if we don't go on to see people together over time. I think what's coming home to me is how every single place has its own sort of model, its own team, and that kind of speaks to the studies to look at how do we disseminate this scarce resource, because nobody has a perfect full team to implement, I think, any of these things fully. Right. So when I think go ahead, Vicki. It's okay.
No, you go ahead.
I'm changing the subject. You go.
Oh, what I was going to say, The other thing that I love is that our previous studies were our one site, right? And this is 22 sites. So this is not an MGH thing. This is palliative care is effective in improving quality of life for patients, right? Like in the outpatient setting, early outpatient setting. And that's what I loved about it, because even though the models are different and maybe there's an embedded social worker, or maybe the social worker sees patients at different times and the structure isn't exactly the same, what is essentially in our common syringe works.
Oh, wait, no. I'm gonna play devil's advocate.
Okay.
I'm gonna pull back to what I remember from the stepped palliative care trial, and Alex asked the question. There's no usual care group here. There's no that third group that's the no palliative care or palliative care. The usual palliative care would be just as needed palliative care, PRN, kind of like PRN social worker, PRN palliative care. Should there have been a third PRN group or third control or usual care group?
You want to take that?
Alex, weren't you gonna debate this with Vicki in Montreal?
No, but I was waiting for the results first so that we could debate.
Wait, what would usual care be?
We have to talk about the results before.
What would usual care? Okay.
Usual care would be usual care, like with you get a consult if you get a consult, but mostly you may not get consults on a lot of these people.
I guess I'll weigh in now since you've called me out on this. If you look at the population who was studied in this study and well, first, let me just reflect on what you've been saying. This was a tremendous undertaking. Kudos to you and kudos to all these sites. And it sounds like they got so much out of this too. And that part of the intervention that maybe goes unrecognized in the article, but is really clear here, is the way in which this, as you said before we started podcasting, the way in which it built community and the way in which you helped each other and helped clinicians and really so that is a really interesting model for how to improve and do palliative care nationally as part of a study or maybe outside of a study. The point I think we're getting to here is that, palliative care has changed a lot since that original study in New England Journal that you're all part of. That if you look back at that population then and the treatments they received, it was almost all cytotoxic systemic chemotherapy and radiation. And you look now at that table 1, characteristics of subjects, and it's like a third immunotherapy, a third targeted therapy. It's like, the treatments have changed. Like you put people on these new, much better treatments, much less toxic treatments in most cases with some exceptions. And the cancer shrinks. They start to feel a lot better. I mean, I was doing a visiting professor thing recently in Cleveland, and they were saying, now we're not called the palliative care team. We're called like the survivorship team. Whoa, that's pretty different. What's happening? What's happening in outpatient palliative care? This is a new day. Can we really say, have the goalposts moved? Are we the reason that the quality of life is getting better, or is it something else? I don't know. When I say we, I'm talking about palliative care because I firmly have drunk the Kool-Aid clearly.
I have 2 thoughts about that, and I'm not going to. I absolutely see your point, and I have had these thoughts myself. I mean, one thing that we were appreciative of seeing is that in both arms, whether the video or the in-person arm, the improvement in quality of life did mirror what we saw in our early palliative care studies prior. And so it was a clinically meaningful improvement on the functional assessment of cancer therapy lung. That's our primary outcome measure. It's the same measure we used in the New England Journal article. But to your other question, which is valid, cancer therapies have been changing dramatically since that original paper came out. And so how do we think about that attribution? And in preparation for the plenary that we gave on this study at the annual meeting for ASCO last year at the American Society of Clinical Oncology, I kind of, as a psychologist, did a bit of a deep dive into therapeutic trials for lung cancer just to see what they were showing with respect to quality of life improvements. And yes, with some of the immunotherapy trials, what we are seeing is sort of not a dramatic increase in quality of life per se based on those trials, but buffering a decrease in quality of life in relative to the control groups. So whereas we are seeing an actual increase in quality of life in this current trial. So I don't want to overstate that, but in terms of some of the data I was looking at from those different novel therapeutic trials, that's what I was sort of gleaning, is that it's more of a buffering effect versus a dramatic improvement in quality of life. So I hear you. You could probably make an argument. Maybe we still need an usual care in these future studies, that this next generation of studies we're doing. It will be a little challenging and hard pressed to get it through an IRB when the standard of care recommendation is early palliative care. So you'd have to make a solid argument to get it through a review board.
Great. Well, I think we've been dancing around the results. What did you find as far as this paper? Your primary outcome was quality of life. Is that right?
Yes. At 24 weeks.
At 24 weeks. Was there a difference? Or were they equivalent?
They confirmed that they were equivalent. Yes, we did. There was an equivalent effect on quality of life at 24 weeks. And we were able to say, pretty definitively, we had to run a bunch of different sensitivity analyses because the rate of attrition was a bit higher than we anticipated. But yes, and of course, because of the pandemic, we did have some video visits in the in-person arm, so we had to run some sensitivity analyses to control for that. But despite all of those, the data were pretty confirmatory, and whether it was either equivalence in all these sensitivities or at least non-inferiority. So I think we can walk away saying we feel pretty good that these two modalities match up.
And can you say more about the magnitude of the quality of life improvement and how it was measured?
Yeah, so on the functional assessment of cancer therapy, a minimal clinically meaningful difference is roughly 6 points. And so for both the in-person group and the video group, the improvement from baseline to 24 weeks was in excess of 6 points.
And in a bunch of secondary outcomes, caregiver quality of life, patient coping, patient caregiver satisfaction with care, mood symptoms, prognostic perceptions, no difference between the two groups, right?
No differences.
One little detail that stood out to me, which really rang true to real life, was that caregivers were actually less present during visits in the video visit.
So you see that?
Oh, yeah, for sure. In fact, I have to often say, like, hey, who else is there with you today? And invite the caregiver to come in to come sit down.
Why do you think that is?
Because they're not driving them in? Or
I think it has to do a little bit with, for some of my patients, I think it has to do with the respite that the video visit provides, the transportation, they're not driving them. If they physically come here, it's sort of just the natural course of things that they'll walk into the room with the patient. Whereas many times I see caregivers kind of running around doing the dishes and stuff in the background.
I think another thing that I would add to that is that it does give the opportunity, I think, for patients to be able to have meetings with their palliative care clinician privately in a way that is often not possible when they are in person. It's hard to find privacy no matter, but also just to have that private space to be with your clinician. And I think that really matters for folks to be able to talk about their experience sometimes without having to worry about the impact on the family member that's standing next to them. So I think that is one of the benefits. It was a kind of unexpected result, but I think that may be part of why.
Also, the portability of video visits. So like just yesterday, I saw somebody while they were in their hotel room taking a trip, which is like what we want people to be able to do. So
I'm hearing that on the one hand, can I just say we're probably all relieved to find that there was equivalence, right? As I see people shaking their head, yes, we're relieved.
Kind of screwed if it was.
What would we do had it been different? On the other hand, we are pointing out that we do expect there to be some differences, like because the caregiver's not there as often, and maybe that allows for more conversations that wouldn't happen otherwise about things like sexual intimacy. We did a podcast about that with Arij and colleagues. Things like experiencing trauma, or other, our goals don't align. I want to tell you now while I have you here, Doc, though they're my caregiver, please listen to what I'm saying now. So we would expect there to be some differences, although they weren't necessarily picked up in this study, or were they?
I mean, what I find fascinating about this is the fact that caregivers attended fewer visits in the video arm versus the in-person arm, a good or bad thing or both? Because on one level, you could make the argument that with the caregiver not being present, perhaps there's a breakdown in communication. People aren't on the same page about the goals of treatment or how they're supporting each other in moving through the treatments, or just even caregiver understanding or awareness of everything that's going on. You can make the flip side argument, which is that perhaps it gives the patient and caregiver just more autonomy to decide when to have a joint visit. And that autonomy allows for different types of conversations and, frankly, maybe just a more reprieve and less burden on the caregiver, given all the transportation issues, et cetera. I was reassured by the fact that we did also measure the outcomes from the caregiver perspective. So we did measure their quality of life, and we did measure their coping and their distress. And thankfully, despite the fact that their participation was lower in the video visit group, their outcomes were not different across the two groups. So that was reassuring. Not only were their outcomes not different with respect to their own quality of life and distress, but also their perceptions of the patient's curability of their cancer or the goal of treatment, right? So where you would think that communication would be a major issue, there were no differences between groups there either in terms of their knowledge and understanding. And then lastly, satisfaction with care for the caregivers and for the patients, no differences. So despite the difference in attendance, I was reassured by those no differences.
I do think it's also interesting, like what as clinicians we've learned that we ended up doing during the study, and the sites would say this for different patient populations. Like, for example, I realized in the video arm, I would need to be intentional when I wanted the spouse to come in, or for you guys, it's always probably the child from Boston. For us, it's always the child from California, right? Like we could say, hey, can you have your daughter from California join, which allowed something different, but we would actually plan it ahead versus it being whenever. I think the other piece we found was there were times when, either oncology or palliative care could say, I think we need an in-person visit. And there would be times that would happen when I couldn't get my arms around what was happening because there'd be a caregiver who I'd be like, there's something, I can't read it quite, right? And we would do an in-person visit to get our arms around what that was. Or if I was worried that there were issues with technology or other kinds of things.
So is that an issue, though, with fidelity? Like how many of the video visit folks were actually being seen in person, or the opposite? Because this was happening in COVID, right?
Great question.
And then all of a sudden, like we started doing all video visits. Lynn, what were you doing?
In COVID?
2020.
I wasn't doing outpatient in 2020.
Oh, yeah, I forgot about that.
I was in the hospital.
We did a massive switch to telemedicine. What happened during this study?
There's also the experience of, I couldn't get there today because there's a snowstorm. Let's switch it to video.
Yeah, we freaked out. Short answer, like we really freaked out a lot for many months.
Years. It felt like years, honestly, that we freaked out. Yeah.
No, if you could design a study for which this type of pandemic would be the worst. The pandemic's the worst. Don't get me wrong, but the worst threat to the validity of your study. Yeah, this would be that study. So that
precision.
But how many people switched from one group to the other? Or I guess they didn't switch groups, but they used the other's modality.
Yeah, we halted recruitment during the first few months of the pandemic so that people weren't being enrolled and randomly assigned to the in-person group, knowing that they were going to get video visits because there was no choice. People had to get video visits. So among the enrolled people who were in the in-person group, we were able to keep their video visits down to less than 6%-ish. Okay. And so that level of contamination was not a threat. We were able to do enough per protocol and sensitivity analysis to show that level of contamination did not threaten the validity of the study and was still confirmatory for equivalence.
Okay, I got another question. Kind of thinking forward now. So they're equivalent as far as outcomes, but video visit, you don't have to beg and borrow and steal rooms. Those rooms could be managed by oncology or somebody else who needs to see people in person. You can stay in your pajamas at home. You don't have to drive in, the commute. Should we just give up on in-person palliative care consultations in the outpatient setting because they are equivalent from an outcomes perspective, but they're not equivalent from just the sheer amount of time, efficiency perspective. Simone, I'm going to ask you first. Your thoughts?
I was hoping that you were going to ask Joe and that I could put my 2 cents in later. But I think 2 things just off the top. I can't imagine, although I have no evidence to base this on, that the models that we create aren't going to include both. And that is also going to be some of the work that we have to do in the future, is to try to figure that out, how to kind of figure out not only that by population, but by like kind of cadence. But I think in terms of thinking about how to be implementing and delivering palliative care in this changing landscape, particularly in the changing landscape of cancer care, and thinking about the different populations in terms of like low or greater symptom burden, and in terms of thinking about how we're using our resources, like pulling all of this together. I think ultimately we will be needing to figure out models that are individualized and that kind of pull these things together. Like maybe we have kind of high touch palliative care in certain situations. And as part of that high touch, we're using both in-person and telemedicine visits in folks perhaps that are not needing quite the kind of heavy touch because perhaps they're in the beginning of their disease and they are going to need kind of a lighter touch for a period of time. Yeah. Again, some type of combination for those. I
love that, because I think that's also what Eduardo Barrera said in the editorial that's attached to it. And he did this wonderful author in the room for JAMA about the editorial. But like, it really does need some individualizing. You feel like that's the case, Joe?
Yeah,
I know we should learn from this.
I think like the good news is we're going to continue to learn from this. So, we talked about the community that we established over the last 7 years with this study. Now we're kind of moving into additional analyses to answer some of these important questions. So one of the palliative care investigator clinicians from Dana-Farber, Isaac Chua, he is really interested in doing some interviews with the clinicians to figure out exactly what Simone was just saying. When did the clinicians feel like in the video visit group that they just had to see the person in clinic? Like, what were the indicators for that? And is there guidance that we can put out there, given just the sheer volume of data and sheer number of clinicians we have in the study, that we can contribute to offer those who are, now training in the video visit world? And so I think there's so much more to come in answering this question, but I don't think there's ever going to be a scenario where it's exclusively video visits. That just won't exist.
I think also that it would be helpful to be looking at some of the care that gets delivered that is indirect and outside of the clinic visit that helps to stitch these clinic visits together. I think that is an area, and I think that is often APP and or nursing run care. And I think that is an area to think about in terms of how does that contribute to what we're seeing here, and how does that contribute to what is in that palliative care syringe.
It's not even what happens only with the patients. It's when the oncologists are popping in the office where the NPs are and saying, hey, can I talk to you about Mr. Jones? And da-da-da-da-da-da-da. And it changes the way they think about how they should be thinking about oncology care for that patient.
I was just going to bring us back to our battle in the beginning.
Oh, the boxing match.
The boxing match.
The rink.
Two corners.
Going in the beginning. When we talked in the very beginning about the in-person visit that the stakeholders all said, we got to do that first. I actually wonder, we said clinicians nowadays, they probably would be fine with doing away with that. But I really wonder what the patient and family perspective is now. Because I think that it's changed, but I'm not sure. And it may have changed in a different way. So I'm going to go on the side of we need in-person presence. I actually do my video visits here from the office, so I don't wear pajamas. And I think we need an in-person presence in the medical center, in the cancer center. Even if we're doing video visits, we need to sort of be here to be at the table. So I'm going to go on the side of in-person.
Huh. Okay.
Like
in person, even you're doing
hybrid,
video.
Yeah. I'm going to say hybrid. I'll do what's best for the patient in terms of how I see the patient. But I think having a presence is super important.
Vicki, you're in a huge leadership position. What do you think about that?
So one thing I think that we have not done as much we've paid as much attention to as we could have, and maybe we will in the future in our studies, is actually, this is really clearly in my mind a triadic relationship. It's the oncologist and the patient, the palliative care doctor and the or nurse practitioner and the patient, and it's the palliative care clinician and the oncology team relationship.
Yeah.
And that relationship, I think, is key in what happens with the patient. And I think your point, Lynn, is really a good one, is that if we're only at home in our jammies, we're not there when they knock on the door to say, hey, can I talk to you about this? And I'm on the fence about whether I should give this third line of chemotherapy or not. And that happens. It really happens.
I also noticed on page 23 in the supplement, that was actually part of it. Like the interaction between the palliative care team and the oncologist.
Yeah, we did add that to our Red Cap form. That is true. But like exactly what happens in those encounters, I don't think we really know. We know that they happened.
Okay, my last question, because we're coming close to the hour. I mean, I think this is absolutely fabulous. We're building the evidence. Joe, you mentioned that there was this guide that you created with your co-authors. Have you ever thought about publishing it so people really understand what was actually in that syringe that you taught all these 22 sites, or you told them that these are the important things to do besides page 23 in the supplement?
Yeah, exactly. Are we allowed to do a little promo?
Yeah.
So we have published. Yes. What's in the syringe is out there. You can buy it. Go on Amazon now. And it's all there.
The trial protocol, like what you did in this trial.
Well, it was before this, but it basically what we did, it was Joe, Jennifer, me, and Julia Jacobson. And we really looked at what have we done, looked at our manuals that we've developed for all these studies, and then tried to help clinicians think about what the tasks are that they're doing with patients over time.
And like coping.
Coping is a big part of that.
And what's the title?
What's in the syringe? I could probably pull one up.
It's actually called What's in the Syringe. So we will have links to the book in our show notes, and we'll have a bunch of other links to the show notes. So all of our listeners, please go to the show notes. But before we end this podcast, maybe we can get a little bit more of Adele. Coming together.
Hello from the other side. I must have called 1,000 times to tell you I'm sorry for everything that I've done. But when I call, you never seem to be home anymore.
That's a no-show, right, Lynn?
Yeah.
That's not good for RVU.
Can I plug HPM?
Yes.
Yeah.
So this podcast is being published the week of the HPNA.
A week before, maybe.
HPN, or a week before.
Yeah. We're moving that up.
There is... What else is happening during the HPM meeting, Vicki?
Can I tell you how excited I am about this year's annual assembly in Denver? I'm super excited about it. So we have several awesome keynotes. The first one on Thursday is actually going to be Krista Tippett and Lucas Johnson from On Being, which is going to be fabulous. And Friday, Reach and Step are going to be highlighted with our very own Joe Greer and Jennifer Temmel and Simone Rinaldi and Laura Hansen from UNC. Toby Campbell from University of Wisconsin is going to be our MC, and we're going to actually have a patient talking about her experience being in the video arm. So I think that's going to be awesome.
Cool.
And then Saturday morning, it's going to be the top 3 scientific abstracts submitted to HPM.
Wow.
So come hang out.
And don't forget about the GeriPal pub crawl Thursday night, 8 p.m.
Yes. Also to note, we are going to be doing a podcast with the abstract presenters, the Saturday plenary session abstract presenters as well. So look for that, dear listeners.
Thank you, everybody, for joining out on this podcast today. That was absolutely fabulous. Great work on the studies that you're putting out there.
Thank you.
Thanks. Thanks so much for having us.
And thank you to all of our listeners for your continued support. We'd also like to thank everybody who's donated over $250 to the podcast over the last year, including
Daryl Owens, Craig China, Mike Steinman and Dorothy Richmond, Diane Meyer, Matt Schuster, Harry Hahn, Elizabeth Chung, Wendy Peltier, Kelly Strait, Jeffrey Galbraith, Ron Sabar, Rebecca Goldstein, Anna Lynch, Deborah and Jeffrey Larson, Krista Masak, Ed Martin, Stuart Oserman, Mo Rizawi, Rochelle Bernacki, Daryl Owens, Mark Wren, Richard Lewis, John Bielenson, James Tulsky, Elizabeth Cobbs, Christopher Heck, Meg Walhagen, Chris Jones. Thank you all.